Okay, so we're going to cover these arrhythmias or dysrhythmias, okay? And we're going to start with rhythms that are still originating in the sinus node, but they're too fast or too slow. And that can still be a normal body response. So for example, sinus bradycardia, well, that occurs all the time when you're sleeping. Or in someone who's very fit. They can be in sinus bradycardia because they have such a fantastic stroke volume. Okay. Sinus tachycardia, well, that can occur with pain, with fever, with hypotension, um, with fear. So lots of things can cause sinus tachycardia. So a heart rate greater than 100 is sinus tachycardia. A heart rate less than 60, sinus bradycardia. It's still using the normal electrical pathway that we've spoken about. Sinus arrhythmia is just the slight differences in heart rate that's related to the fact that we're breathing at the same time. And when we're breathing, we're generating negative and positive pressure within the chest, and that creates slightly different amounts of blood that are returning back to the heart, just slight. So we call that sinus arrhythmia. It's not abnormal at all. And then we're going to go into the atrium after the sinus node, and we're going to talk about rhythms that can occur from the atrium. So they're going to be abnormal because they didn't originate from the sinus node, right? They're going to be abnormal. All of these rhythms below the sinus node are going to be abnormal rhythms because the normal rhythm should have started at the sinus node. So junctional rhythms or arrhythmias, well, that's just a fancy word for rhythms that started at the AV node, the junction between the atrium and the ventricles. Okay, we'll talk about them. And then ventricular rhythms, so rhythms that began within the ventricle. And we'll talk about different rhythms, some of them quite dangerous, that started within the ventricle. They didn't use the normal electrical pathway. And then finally, we're going to talk about heart blocks. So a heart block has everything to do with the AV node. I mentioned that the AV node is the guard of the electricity that is coming from the atrium and trying to get through to the ventricle. And the AV node is deciding when it wants to allow it through into the ventricle. And if the AV node gets sick or damaged, say in a heart attack or ischemia, so poor blood supply to it, it can then stop the conduction from getting into the ventricles, and that's going to be a problem. And we'll talk about heart blocks. Okay. Okay, so let's look at some rhythms. Okay, and here's the first one: normal sinus rhythm. So what does that mean? Well, it started with the sinus node, turned into a P wave. Then the P wave then went to the AV node, into the ventricles, caused a QRS, and then which is ventricular depolarization, and then a T wave, ventricular repolarization. What's the heart rate? Between 60 and 100. If it's less than 60, sinus bradycardia. If it's greater than 100, sinus tachycardia. Is it super regular? Because the SA node sends out regular electrical signals. Okay, so normal sinus rhythm should be super regular. So when you look from QRS to QRS, the time between all of them should be identical. Okay, so a normal rhythm, it's not irregular at all. There's a P wave before every QRS. Okay, so just go along here and determine, is there a P wave before every QRS? Yes, there is. Is it less than 60? No, it's not. Is it greater than 100? No, it's not. So normal sinus rhythm, that is the absolutely normal rhythm of your heart. Okay. Just to add a bit more detail here, the PR interval that we're going to talk about when we talk about heart blocks. Is it less than one large pink box, meaning between two bold pink lines. And if the answer is yes, it's less than the time of between two bold pink lines. That's 200 milliseconds or 0.2 seconds. Perfect. Okay, if it's longer than 0.2 seconds or 200 milliseconds, then we're going to call it a first degree block, but we're going to come to that. So don't worry. I'm going to repeat that. Okay. So understand normal sinus rhythm. There's no treatment for it. It's a perfectly normal rhythm. PQRS, PQRS, heart rate between 60 and 100. Okay. And if you want, you can actually map out the heart rate. Start with the first QRS in the top left-hand corner and just go over one large box. And if there was a QRS there, it would be 300. Go to the second box, or the second bold line. If it was there, it would be 150. If it was at the third line, it would be 100. And it's close to the fourth line. That would have been 75. It's not quite there. Okay. So 300, 150, 100, 75, and then 60. If we were to do that quick and dirty way of calculating heart rate. Okay, sinus bradycardia. Okay, is there a P wave before every QRS? Because there should be if we're calling it sinus. And at the bottom rhythm strip, it's actually easier to see the P waves than the top rhythm strip. You can see it's P QRS, P QRS. So I'm referring to the second rhythm strip down. Okay, not the top one because I don't see the P waves as clearly there. I can still see them, but they're not as tall. The second one down, you can see the PQRS. It's a small QRS. PQRS, PQRS. Okay, and why are we calling it sinus bradycardia? The heart rate's less than 60. Okay, it's still nice and regular. It's coming from the sinus node. It's less than 60, maybe because the person's sleeping. Maybe because they're on too much metoprolol or too much of a calcium channel blocker, such as diltiazem, and it's slowing down the heart rate from the sinus node. Okay, so what's the treatment? Well, if the person's sleeping, just let them sleep. It's normal. The heart is not beating as fast because it doesn't need to, so there's no treatment. If somebody comes in and they've been given too much, say, metoprolol or diltiazem, and they have a sinus bradycardia with a heart rate of 40, we've just slowed them down too much. Well, that might be causing them symptoms. They might be dizzy. Their blood pressure might be low. They might be falling over at home because of the low blood pressure. So in that case, we could give them a medication such as atropine to increase the heart rate. Typically what we do is we stop the metoprolol or diltiazem and allow the heart rate to come back up. Okay, but if they're really symptomatic, sure, we could speed up their heart rate with atropine, which is an anticholinergic drug, so it's going to allow the sympathetic nervous system to stimulate the heart more. Or we could use a direct stimulant on the heart, such as dopamine or epinephrine, which is directly going to tell the SA node to beat faster. Okay? So sinus bradycardia, it's using the normal electrical pathway of the heart. It's just going less than 60. Okay, so sinus tachycardia. So the heartbeat or the heart rate is greater than 100, but it's still using the normal electrical pathway of the heart. Okay, so in this, on the left there, on these rhythm strips, let's go to the top one. Is there a P wave before every QRS? Yes, P, QRS, P, QRS, just happens to be going fast. So how fast? Well, just choose one of the QRSs that lands on a bold pink line, because it just makes it easier to count. So the third QRS on the top rhythm strip lands on a bold pink line. So go over one large box. Does it land there? No. Okay, the heart rate's not 300. Does it land on the next one? Yes, it does. Heart rate's 150. So this is a heart rate of 150 beats per minute. Where's the rhythm coming from? The sinus node. It's sinus tachycardia. Okay? What causes sinus tachycardia? Well, if you go for a run, you'll have sinus tachycardia because your heart wants to generate more cardiac output, so it increases the heart rate. If you're fearful and anxious, you will get sinus tachycardia because of the sympathetic nervous system stimulating the heart to get you ready for whatever's going to happen. Fever will generate a sinus tachycardia. Okay, so if you have a child that's febrile, you're going to notice their heart rate's going to be fast, right? Because the body is generating more cardiac output because it's at a higher metabolic rate due to the fever. Okay, the most important one, hypotension. So someone who's bleeding and they're hypotensive, and then we notice, oh, wait a minute, their heart rate's 130 or 140 beats per minute, sinus tachycardia, but their blood pressure is still okay. Okay, we better go looking for a source of bleeding because we can't. Sinus tachycardia needs to be explained from something. So fever, pain, fear, and most importantly, hypotension or bleeding from somewhere. Okay, because the first sign of hemorrhage or bleeding when someone's going into shock is going to be sinus tachycardia. The heart is generating a faster heart rate to maintain blood pressure. And as they lose more and more blood, the heart rate's going to go faster, but then their blood pressure is going to start to drop. So we'd like to try and catch shock before their blood pressure drops, and that is sinus tachycardia. So we treat the problem, okay? So if the problem's fever, okay, acetaminophen or ibuprofen. If the problem is anxiety, okay, we'll talk to the patient, we'll try and reassure them. We may even need to use a sedative. If the cause is hypotension, well, we need to give them fluids if they're dehydrated. We need to give them blood if they're bleeding. Okay, so it just depends on what the cause of the sinus tachycardia is. We never slow down sinus tachycardia. It's there for a reason. We wouldn't give someone a beta blocker or a calcium channel blocker just to slow it down. The heart is responding to something, and then we need to address the cause. Okay, so let's get into some rhythms that don't originate from the SA node at all. So we've spoken about sinus tachycardia. Okay, that starts at the sinus node. It goes through the same pathway, the normal electrical pathway, but it's fast. So we'll call it sinus tachycardia. We spoke about sinus bradycardia. It's using the correct electrical pathway, but it's slow. Sinus bradycardia. Okay. Let's talk about this one, supraventricular tachycardia. So supraventricular is just a fancy word for above the ventricles. So this is actually originating in the AV node. It's not starting in the SA node. And what happens in the AV node with this condition is that we can be born with an electrical nerve bundle in the AV node, and sometimes the electricity gets stuck in this circuit of nerves, and it just goes in a circular pattern within the AV node, and it sends out multiple signals to the ventricles to depolarize. Okay, nothing to do with the SA node. Okay, so we should not be seeing P waves. Okay, this one's tricky because it can look just like sinus tachycardia. Okay, because when we look at the upper rhythm strip here, you could say, well, there are P waves here. And I wouldn't really disagree with you, except for the fact that over time, you start to realize that those aren't P waves, those are actually the T waves. And it's only because it's tricky because it's going so fast. Okay. So again, this rhythm is from a nerve bundle in the AV node, and the electricity gets caught in it, and it goes in a circular fashion, and it's stuck in that electrical circuit. Okay, and we want to get the patient out of that, out of this, because their heart rate is beating fast. So we don't want them to stay in this for a long time. This rhythm is typically in young people, so children, teenagers, 20-year-olds, 30-year-olds. It can happen at any age, but typically you're presenting earlier on in life with this rhythm because you have this abnormal bundle that's creating this rhythm. Okay, so what can we do? Well, the first thing what we really want to do is we're going to check vital signs. So we're going to check the heart rate, we're going to check the blood pressure, we're going to talk to the patient to see if they're perfusing their brain properly. Are they confused? Are they dizzy? Do they have decreased level of consciousness because this heart rate's going so fast? Okay. If you wanted to, you could actually calculate the the heart rate of this at the top rhythm strip. Just choose one of those QRSs, preferably one on a bold pink line, but you don't have to, and then just go across. If it lands on the next bold line, 300. The next bold line, 150. This one happens to be going at about 150. Okay? But this rhythm can go at 200, 220, 250. So super fast rhythms. So because it's abnormal, we want to stop it. We want to get someone out of this rhythm. And the first thing we can do is what's called a vagal maneuver. And there's a slide coming up on a very effective vagal maneuver for SVT. So it's typically the first thing that we do. So no medications, we try a vagal maneuver. We used to push on people's eyeballs. We used to put ice packs on their forehead. We used to massage their carotid artery. Those are all vagal maneuvers. We don't use those. We don't do those so much anymore. Because there's a new vagal maneuver that's much more effective, and most people don't like their eyeballs being pressed on. Okay, and we try not to massage the carotid artery because we could actually, it's rare, but we could actually release a clot or a plaque from the carotid artery that travels to the brain, causing a stroke. Okay, so the vagal maneuver didn't work. It only works in about 25% of people, but that's fantastic because we didn't need to use any drugs. Let's go to a drug now. So adenosine is the drug that we use for this rhythm. Adenosine is actually only used for this rhythm, not for any other rhythms that we talk about. Adenosine is a very short-acting drug that basically is going to turn off the electricity to the heart for seconds. Okay, so we need a big IV, typically at the elbow, not in the wrist, at a minimum at the elbow in the antecubital fossa. Put a nice juicy IV in, and the adenosine needs to be pushed in really fast because it doesn't last very long in the body. The adenosine travels to the heart and it turns off all electrical activity in the heart from anywhere. SA node, AV node, so it's basically doing a reset of the heart. And when you reset the electricity of the heart, what typically happens is the SA node turns on again and you go back into normal sinus rhythm. And that's the idea of adenosine. The key to adenosine is we need to warn people before we push it that you're going to feel miserable. You're going to feel like you're dying or there's a sense of doom coming. It's only going to last 5 seconds, and we'll help you through it. And then your heart's going to start to beat normally again. And that occurs in about 60% of people that we give adenosine to. We can repeat it. If it didn't work the first time, we can increase the dose as well. Okay? So really important to counsel patients about how they're going to feel when they get adenosine for this rhythm. It's very short-lived. It only lasts about 5 to 10 seconds. And during those 5 to 10 seconds on the monitor, there's no electricity. It's a flat line. And then normal sinus rhythm typically starts up. Okay? So it's really nice to see that when we give adenosine. Synchronized cardioversion, that's just electricity through the chest. And we're going to talk about the difference between cardioversion and defibrillation later, but you could just see synchronized cardioversion as I'm giving electricity through the chest. Okay, so giving someone electricity through the chest is basically the same as resetting the heart. So that's what adenosine did in a chemical way, but electricity through the chest does the same thing. It basically just does a full reset of the electricity to the heart. And what do we hope happens? Normal sinus rhythm starts again. Okay, so we can use electricity for this rhythm. We can use a beta blocker or a calcium channel blocker just to slow down the heart rate if we wanted to. Typically we don't. We're either going to use adenosine or electricity in the form of cardioversion. Okay, but if we wanted to, we could just slow it down. But usually we like to get people out of this rhythm. Okay. Now, say we get someone out of this rhythm and they're back in normal sinus rhythm, which is the bottom rhythm strip there. So P, QRS, P, QRS. Well, they still have that abnormal pathway in their AV node. So we can send them for what's called electrophysiological studies, EPS studies, and they go to a lab and they study the nerves of the heart, and if they can find the abnormal pathway in the AV node where it's causing this really fast rhythm called SVT, they can burn it, they can ablate it so that it doesn't keep on recurring. Okay? Otherwise, the patient can get recurring SVT. And some people just wait a bit. They wait for the second time or the third time before actually going for cardiac ablation. If you've had one episode of SVT, you're always at risk for getting another one, of course, but it might be a month, it might be a year, it might be 5 years. There's no way of predicting. Okay? Okay, so this image is just showing you a new version of a Valsalva maneuver that we use in SVT. Okay, we could actually use it for any rhythm where we wanted to use a bagel maneuver. Okay, but this is pretty classic for SVT. So when you're looking at this image, at this video, just ask yourself, well, why is he breathing into this this tubing? Or often we get people to breathe or push air forcefully into a 5 cc syringe with the plunger still in, and we ask them, try and blow this plunger out of the syringe. And they never can, but what it does, so let's just go through this and what the patient does. They take a big breath in, they put their lips to the plunger, to the syringe or to the tubing, and we ask them, blow as hard as you can. Okay, so they're blowing as hard as they can for a few seconds, and they're sitting upright. Okay, and then we put the head of the bed down, put their legs in the air, and ask them to take a big breath. Okay, so let's go through that a bit. When they're breathing really hard into this syringe, they're generating a lot of pressure in their chest. So that's stopping the blood from coming back to the heart. And then we tell them to take a big breath, we lie them down and put their legs in the air, and suddenly this huge rush of blood comes back to the heart. Because when you take a breath, you generate negative pressure in your chest, and it sucks the blood back to the heart. Okay, so that, and when we put their legs in the air, it generates even more blood flowing back to the heart. And by causing this sudden flow of blood back to the heart, the right ventricle suddenly sees this volume of blood coming back, and it says, whoa, there's a lot of blood coming back to the right ventricle. I'm going to try and slow down my heart rate because I'm getting all this blood. So basically it's a way of stimulating the parasympathetic system to break this fast rhythm. Okay, so that's the pathophysio or the physiology behind this Valsalva maneuver, or what we call a vagal maneuver. Remember, a vagal maneuver is basically anything that's stimulating the vagus nerve, okay, which is a parasympathetic nerve. Okay, so it'll make sense if you understand I'm generating positive pressure by breathing into this tubing, and then I'm going to take a big breath. I'm going to lie the person down and put their leg in the air, and all this blood's going to rush back, causing this huge bolus of blood to go back to the heart. And the parasympathetic nervous system is going to say, whoa, better slow down this heart. There's so much blood coming back to it. I don't need to go this fast anymore. Okay.